My name is Volker Duda. I'm working at the University Women's Hospital for about 30 years now, and I'm leading the senological diagnostic, doing our own mammography, breast ultrasound, and interventional procedures as core needle biopsy and vacuum-assisted biopsy. Patient we have seen had a small cancer that was diagnosed in the mammography screening program, and they have told us that it's very, very small and she needed only a small excision and everything would be all right. And then we looked at the breast. The breast was relatively big, and the cancer we saw from the pictures we have known from the mammography, from the screening program, and from the ultrasound they did there, made the impression that it would be really a small cancer. And then we did our routine scan and looked at this small cancer from various sides, and we saw that there was a small echo-poor lesion in the center, but that there was a much greater echogenic rim around, and through this rim there were some ductal structures we saw, and they had a very interesting figure, so that I didn't know if it would be really milk ducts or something other. And then I used the color Doppler and looked at these structures and saw that there were various vessels that went to this small echo-poor lesion. And if you looked at these vessels and looked at the echogenic rim, you got the impression that this cancer would be something bigger than we had assumed by only looking at the B-mode image. And then we did elastography and saw the same impression like we did by the color Doppler. And we saw that the elastographic region was stiff in a much greater amount than the echo-poor lesion had shown us before. And that gave us the impression that we should do a wider excision than primarily planned by this. And that was also confirmed by the 3D ultrasound. In the coronal plane, you could see that this reaction on the surrounding was much bigger than we thought primarily. And you have to consider that breast cancer that measures 1 centimeter has an age of 7 to 10 years. So that's much time to react with the surrounding. And you can't see anything by the B-mode picture. Okay, it's the beginning, but it's not the end. It should not be the end. By none of our patients with breast cancer, I would rely only on the B-mode image. But I took in account all these add-ons as Doppler ultrasound, elastography, and three-dimensional ultrasound. I think it's very important to do all these add-ons in addition to the normal B-mode image to get all informations to get the right procedure for the patient to help her getting rid of this cancer. After you have finished the examinations for the patient, it's of course interesting for the people who are dealing with this patient further on to show the results of this examination. And very interesting is the modality for the three-dimensional ultrasound to show that this coronal imaging is very important to get an idea in which way this small cancer is spreading into its surrounding, and what do you have to do when you will do a surgical excision for this patient to do the right things and to get the carcinoma perfectly out of the breast.